Thank you, Professor Sameh, to restrict for your time. Because we are late, we can take one question or cancel one question for each speaker. Any question for Dr. Ali Abu Rahma?
Any question for me first? You want me to ask, because I'm going to ask question to our last speaker. Any question for me first?
Any question for Dr. Ahmed Sayed? Dr. Ahmed, what about shunting? You need shunt or not for during the anastomosis regarding the brain perfusion? Okay, thank you. For Hisham Sharaf.
Ahmed.
Asking Professor Dr. Hisham Sharaf about the timing of intervention post-injection. You clarify 24 hours after. If more time goes, there is a risk or there is a disadvantage of intervention?
Tumor. They get the vascularity from the branches, small arteries from the external carotid artery. So when we do embolization, if we postpone the surgical intervention, it may revascularize again, and we lost the benefit of embolization.
دكتور هشام، آخر سؤال للدكتور هشام شرف. حضرتك قلت إن أنت بتعمل pre-operative embolization في الhuge carotid body tumor and you recommend surgery after 24 hours. Do you think this time is enough for regression of the tumor size or shrinkage of the blood vessel and you get what you need? And you said that you can aid particles to the coils. I don't recommend particles at all through cerebral circulation. What do you think?
This is a good comment, but when I searching in the literature, I see that some authors preferring the particles in a small sized artery that can withstand the presence of the coils. But as you mentioned, there is some complications of injection of onyx or particles to can do perfusion or diffusion to the branches of the internal carotid artery and make some sort of TIA after the embolization or brain infarction. So this is one of the drawbacks of this technique, but it is mentioned in the literature. We prefer using of coil because of there is no for diffusion or perfusion of the branches of the internal carotid artery after putting the coil. But sometimes it is very teeny, small arteries not accepting or not withstand the presence of coil.
I agree, Dr. Khaled. We have to emphasize on using some thick material that is held within the highly vascular tumor because it is not just the embolization of the small fragments of the mycoembolized materials, which may even be big enough, around 300 microns. It can shunt through unknown and invisible and undetectable extracranial, intracranial bypasses that cannot be visualized in any kind of investigations. And this happened with me, and I have a patient with embolization with a retinal artery occlusion and a total loss of vision on that side.
I agree with this concept. We must be careful during this embolization to shunting of the embolizing material to internal carotid artery. Exactly.
Any questions for me?
Yes.
Yeah, sure. We're going to close the session, but anyhow.
Okay, Dr. Sameh.
Yeah, sure.
Dr. Ali?
Yes. Actually,
Could you let me ask before you just for certain reason? Dr. Ali,
yes.
you would like to start or you can allow me?
I just hate for the junior people here to be thinking primary closure is still standard of care.
Right.
Go back to the clinical guideline, which we just published a year ago. A randomized trial, Aburama's published 12 randomized trial with over 1,000 patients. Patching is the answer. However, there is casual situation where primary closure might be justified if the artery is above 6 millimeter. And if you are rushing but it just no way you could convince anybody you need to do primary closure for most, if not all patients. And if you do want not to put a patch, that's fine, do a virgin technique. Chance of infection or bleeding because of the patch is less than 1%. I don't know about Egypt, but even in America, the patch is $70. Unless in Egypt it's more expensive, which shocked the hell of me. The other part about the pulsating mass that's almost remind me with the ectopic. I didn't get a chance to ask that question. That's like the apparent subclavian artery, same phenomenon, and you could approach it with the same methodology without, I have done probably a dozen of these. You don't need to open the sternum, sting graft, and if you want to detour something, you detour it. So it's doable, but I bet you this what exactly this case was, but it's very rare as you suggested. Champlain 3 is still controversial, embolize or not, and I'm not sure you must operate in it, so I rarely embolize. I have done maybe 2-3 dozen of carotid body tumor. 1 and 2, no. 3, maybe. But I'm not sure why exactly it has to be done 24 hours. But that's a great job, sir.
Yeah, as regard the patch graft is not beneficial at all. That's why we are here, and this is our study, and this is our results. We found no significant difference between the primary and patch graft, but a little bit as regarding raised stenosis for the patch graft, but it was high in the infection rate. As for the RCT, yeah, we can respect it, but at the end, we are here for this just to exchange our knowledge, even here in Egypt or outside. As the embolization, Professor Hisham Sharaf, if you have any comment? Yeah, sure. Yeah, sure.
Very, very small sample size.
Yeah, sure. I appreciate this very much.
It's not going to make a difference. So the p-value will not be significant. But when you do 1,000, then you will see that difference.
Yeah, sure. Thank you. Any other questions?
Okay, Dr. Sama, you know you are my close friend, so I have 2 questions for you. First one already answered by Dr. Ali, so I will ask you the second little questions. You mentioned you are going to do a patch just to widen the artery. Just for clarification, you are widening the artery or to avoid stenosis? Just explain. What is the right?
You mean to answer the question why we are going to do a patch graft?
No, we are doing the patch to widen the carotid, internal carotid artery, or to avoid stenosis?
No, to prevent re-stenosis in the future.
No, I mean technically speaking, you are put a patch to widen the artery or to just to avoid stenosis? I mean to restore the normal.
Immediately at the time of the operation, we are doing widening of the artery to prevent re-stenosis in the future.
I think it's better to just back to normal size of the artery rather than to dilate the artery. This is my opinion. I don't know what about the floor. You are insisted about dilatation. I think it's better to make it natural, like the same size before.
I think what you...
Yeah, sure.
Because you are my close friend.
I don't know if technically if we are doing a patch graft to the artery, are we going to the normal size of the artery or we are going to widen the artery?
One important point, if you are planning to dilate the artery or wide the artery, for how long, for how much? Anyone can put a very wide patch to make it like the same size of aorta. So I think to justify your answer, say back to normal.
Yeah, sure.
My friend.
We will consider it.
Thank you.
Thank you so much. Now we are going to close the session. We are late like 2 hours. We are calling to the second session, please.